Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 2 of 3 of the Treatment Progress in Triple-Negative Breast Cancer, Improving Disparities and Outcomes with New Approaches podcast series. I'm Dr. Bill Gradishar, and I'm joined by Drs. Yuan and Rita Nanda. I hope you enjoyed our first podcast on the biology and burden of triple-negative breast cancer, or TNBC. In this second virtual roundtable conversation, we review the latest clinical evidence and personalized management approaches in TNBC to enhance patient-centered care. The ability to tailor individualized and effective treatments for each patient is of particular importance in this group of patients due to the high risk of distant recurrence and death.
So our next segment will be focused on the different treatments that we have for the management of metastatic triple-negative breast cancer. And as Bill had very eloquently outlined early on, there are definitely biological differences amongst the different subtypes of triple-negative breast cancer. As you can imagine, as compared to other forms of breast cancer, triple-negative breast cancer is perhaps the most heterogeneous because, again, these tumors are grouped together because of what doesn't drive them. So what they lack of ERP or HER2, as opposed to driving mutations or driving alterations. And many different groups have looked at different subtypes. We've done gene expression profiling, and there's heterogeneity here. Some subtypes of triple-negative breast cancer benefit better from chemotherapy or DNA damaging agents or immunotherapy. And then some don't respond to anything, which is very disappointing. I have a lot of patients who come to me in clinic and say, well, what subtype of triple-negative breast cancer do I have? Can you send that test and tell me? And there's really not a role for this clinically per se, although, the luminal AR subtype, there's interest in potentially repurposing some of the drugs we use to treat prostate cancer for this subtype, because at the end of the day, we still have the therapies that we have, and this isn't going to drive clinical decision making. And so it's not something that we do clinically, but we've investigated as a research tool to identify novel targets. And we've already made some advances in the management of triple-negative breast cancer, based on work like this and the work of others. And so here's a nice, summary of some of the biomarker-driven therapeutic strategies we've got for the management of patients with triple-negative breast cancer, some in the advanced cancer setting, some in advanced and early stage disease. But in thinking about these kind of 4 distinct subtypes, there's the subtype that's really driven by the alterations in DNA repair. They are tumors that are unable to repair their DNA and may be more sensitive to platinum-based therapies. That this is where our BRCA1 and 2 mutation carriers fall. We've got olaparib and talazoparib that's available for these patients. Thinking about those that have an immune-enriched environment and may be more amenable to immunotherapeutic strategies, immunotherapy alone or immunotherapy in combination with chemotherapy. We have an approval for pembrolizumab, and we'll dive a little bit into some of these trials later. And then I think the next wave of advances that we've made and are making for the management of advanced breast cancer are with the antibody drug conjugates. So things like sacituzumab govitecan, which targets TROP2, trastuzumab deruxtecan, which is targeting HER2 positive, as well as HER2 low expressing advanced breast cancers, a lot of advances that we've made. And here are the NCCN guidelines for the appropriate testing recommendations for patients with advanced stage disease. We all encourage rebiopsy at the time of recurrence because receptors can change. But it's also a great opportunity to think about some of the other tests that we want to do on the tumor or genetic or genomic testing of patients. And I don't know, Yuan, if you want to weigh in, or Bill, about anything here that you like to focus on, or things that you think may be missing in terms of how you think about your patients, and when do you incorporate genetic testing? When are you testing for, are you doing next generation sequencing right away? Or are you waiting? When do you test for PD-L1? I don't know if you wanted to weigh in, Yuan, about some of the testing that you're doing in your patients with advanced stage disease.
For advanced unresectable or metastatic, I think we tend to introduce NGS sequencing early, and also absolutely testing PD-L1, because so any one of these potential targetable findings will change or maybe triage our selection of therapy. So I think I completely agree. I do NGS immediately, but sometimes I actually do that for people who had minimum responses to neoadjuvant chemotherapy, immunotherapy combination, sort of in preparing for the next perhaps clinical trials or other future options.
No, I would share the same sentiment that we do NGS testing, at the time of metastatic disease, early, looking for, PD-L1 status. I think the testing for BRCA abnormalities or PALB2 has increased significantly, obviously, as we have therapeutics that work in that space. It's useful to know that information, even if you're starting with some other therapy, as an example, immunotherapy. It's important to know. So I do think that these things are important. I'm still waiting for my first NTRK fusion. I've yet to see it, but I know it's out there somewhere. But in all seriousness, those things are becoming more and more important. And when you think back, and I think we all are in the same relative level of being out of training, it used to be that the slide was populated with chemotherapy, more chemo. That's all we had. So this is, I think, a reflection of, progress, that we do have options. We have selective therapies. They don't work for everybody, but I think this is progress.
Yeah, no, I 100% agree. And I think a lot of us probably have BRCA status or other germline mutation status, maybe from the early stage setting too. But if not, absolutely an opportunity to get it at this point. Mismatch repair, microsatellite instability, tumor mutational burden. Have you all had that opportunity to treat patients with immunotherapy, monotherapy in your practices?
I have not yet to identify the first MSI DMMR, but tumor mutation burden high. I've seen a couple of cases, and I actually had 2 NTRK fusion when the initial FDA approval came in. We went back to look at our 500 patients database. We found 2, but the patients were no longer able to get treatment. So I think absolutely this is so critical. I yet to treat with TRK inhibitors. Yes, same here.
So I too, I don't think I've had anybody with MS high, but TMB high, even in ER positive patients, I've had a couple. And with monotherapy, at least one of them that I can recall was on it for an extended period of time. So it happens. It's not frequently, but it happens.
Yeah. And some of the studies, I think Keynote 119, it was about 10% of triple negative breast cancers that have a tumor mutational burden of more than 10 mutations per MB, but I don't know that I've seen that in my practice. Although there's probably some overlap between the PD-L1 positives and that. So I suspect some get captured there and end up getting immunotherapy as part of that. So here, the Olympiad and Embraca trials, the randomized phase 3 trials, which led to the approval of olaparib and talazoparib for advanced BRCA1 and 2 associated breast cancers. These trials included both hormone receptor positive as well as triple negative disease, and pretty similar findings here. You can see a 3 to 4 month improvement in median PFS, no improvement in overall survival, but certainly an improvement in median PFS. And I think what's not shown here is the improvement in quality of life with these agents. So are you reaching to, Bill and Yuan, your PARP inhibitors first? Are you doing some chemo first? Does it depend on the situation? Do you do, if somebody's fortunate enough to have a mutation and be PD-L1 positive? Are you incorporating immunotherapy first or PARP inhibitor first? Because I know that question comes up an awful lot.
Yeah, I tend to use immunotherapy first. And then if they have a BRCA mutation, this would be certainly something I would think about. And the other thing that's interesting about these data, although it's not shown on this slide either, is it's often forgotten that the response rate was actually pretty good with the PARP inhibitors compared to chemotherapy, actually better. So not only do you get the PFS advantage, you get the response advantage as well as the quality of life.
Yeah, no, that's an important point, Bill. It was double. So 60% range versus 30%. So that's, I think, and these responses are quick. I think, sometimes I'll hear, oh, I want a quick response, so I want to use chemo before the PARP. But PARP inhibitor responses can be very quick. So just as quick, if not quicker than chemo. And the double response rate certainly makes that, worth it to go to those first. What about you, Yuan? Do you use immunotherapy-based treatment first, or do you use PARP inhibitor first for patients, that small segment of the population that might have both PD-L1 positive and BRCA-associated triple negative breast cancer?
I tend to use PD-L1 inhibitor if it's PD-L1 positive and reserve the PARP inhibitor at the second line. But I completely agree with both of your assessment. The response rate is so quick. I remember I had a patient who has significant pleural effusion, barely be able to breathe. 2 weeks in, she's able to bike and go back to gym, go back to work. So that's definitely a huge advantage, especially quality of life. Now, maybe perhaps I could introduce some discussion point regarding now the modern regimens, such as Keynote-522. We're starting to utilize weekly carbotaxol followed by AC. And one question was not addressed in the both trial is carbo was not compared. And in breast cancer world, how do we handle the question about carbo sensitivity? So, for example, those fast progressor, if their last exposure to carboplatin was within or approximately 12 months from last dose of carbo, if they relapse, would you choose to have olaparib first? Or, how do we handle the carbo sensitivity question in the breast cancer world?
Yeah, I think, neither one of these studies had platinum based as the chemotherapy of physician's choice option. I do think that there was some concern that, that might not allow the PARP inhibitor to show as much benefit as compared to a platinum-based therapy. But I think, there are some anecdotal reports that, patients who've progressed on a PARP inhibitor or platinum aren't as sensitive to the other agent in sequence. But I still think, I would try a PARP inhibitor in those patients who've had prior platinum. I don't think the cross resistance is going to be 100%, but welcome your thoughts, Bill.
Well, I'm also curious. I don't know if this is part of your question as well, Yuan. So if somebody progressed on adjuvant platinum-containing regimen and then has metastatic disease and is PD-L1 positive, would you revisit a platinum? And I guess, I probably would, thinking, again, that's how the regimen was developed. But, I wouldn't have certainly any hesitation with using a PARP inhibitor, or at least trying it. But I'd be curious to know what you both think about that patient who's had a platinum in the adjuvant setting and then has metastatic disease.
Yeah, I don't know if it's right to use 6 months or 12 months as a mark, but I think we all felt or fear that perhaps the PFS is a little shorter, but it wouldn't necessarily stop us from trying it again. And we're trying to stick with evidence. As Keynote 355 that definitely have that 3 choices, and then taxane is also included. So I think it's posing a lot of challenges regarding chemotherapy backbone. Which one is best or more making more sense?
No, I agree. These data and the patients who were enrolled in this trial, obviously this was pre-immunotherapy, pre-Keynote 522, right? Pre-neoadjuvant platinum-based therapy, but I still think it's worth a try. There's still an opportunity to potentially benefit patients. And I think not everybody's the same, but I do agree that if somebody's recurred very quickly after neoadjuvant platinum-based therapy, that it's less likely they'll have as good of a response to PARP inhibitor-based therapy in the setting of mutation. So why don't we, with that, move on to focusing a little bit more on immunotherapy in the metastatic setting. So I think, again, you all are well aware of these data. It's been published for a few years now. We've had pembrolizumab plus chemotherapy as an option for PD-L1 positive advanced triple negative breast cancer. And again, impressive improvement in PFS and more notably, an improvement in overall survival. So I heard you both say, if somebody's got a mutation and they're PD-L1 positive, you're going to favor the immunotherapy-based treatment. And the reason for that, I would agree, is because there's a survival advantage here, which we don't see with PARP inhibitors in patients with metastatic disease. And there are these patients who have remarkably durable responses and a subset that are even cured. But I wonder what you all think about these data now that we've got pembrolizumab in the neoadjuvant and adjuvant setting for early stage triple negative breast cancer. And some of these patients are going to recur. Would you re-challenge with pembrolizumab in the metastatic setting for patients who've recurred after, neoadjuvant and adjuvant pembrolizumab? Do you feel differently depending on how long it's been since they completed therapy? If they're still on pembrolizumab, would you just give them a different chemotherapy and add it to the pembrolizumab if they're PD-L1 positive? I think that's an area where we don't have any data. So just welcome your thoughts about that.
Well, I think you answered the question with your last comment. So it's sort of a data-free zone. And, the typical thing we say, whether it's justified or not, particularly as it relates to immunotherapy, is whether the time since you last got it makes any difference. I have no idea. But I would still sort of favor the idea that if it was at some distance from your prior exposure, I would try to leverage the potential benefit from it. Whether that's right or wrong, I have no idea. But that I wouldn't dismiss the idea of trying it again.
One thing we don't have data is also if patient got neoadjuvant or adjuvant pembrolizumab, when these tumors recur, would PD-L1 still persist? Because in this trial, if I remember correctly, it was 40% of the patient had PD-L1 expression defined by 22C3 antibody. But does that change? And then all these evolution or clonal changes we saw earlier, how much does that impact our patients? And I had tried to do some repeat biopsy. My anecdotal experiences, the PD-L1 level seems to be going down. But I'm not aware of we have a good data set to inform us regarding that.
Wouldn't we have to go back retrospectively sort of to look at the pool of patients because since we're not testing in the neoadjuvant adjuvant setting, to really define what is going on? Because I don't know the answer to that question.
Yeah.
So my pathologist did testing, although we keep saying in our tumor board, do not test the early stage, initially diagnosed, regardless PD-L1 status, it doesn't matter. But we actually found some incidentally they were tested and it were initially positive and later on become negative. Yeah, very anecdotal. I mean, it will be worthy of a study and if we do a correlative, like a real world data sets.
I think it's hard though, Yuan, to know if that's really loss of PD-L1, because if you think about it, and the data that we know from Keynote 86, for example, is that PD-L1 positivity varies by site. And the breast and the lymph nodes are much more likely to be PD-L1 positive as compared to, say, the skin or a liver met. And so it's, unless you're looking at the same tissue over time, which isn't what we're looking at here, right? Because for early stage disease, you're looking at a breast. And with metastatic disease, it's usually not, right? Then it's hard to know if are you really losing it? Or is it just that there's difference and there's heterogeneity? So I think it's hard to know. But, I think if if they're PD-L1 positive at the time of recurrence and they had immunotherapy before, it sounds like I'm hearing from you, if it's been some time since they were on immunotherapy, you would consider re-challenging them with immunotherapy and chemotherapy. And I think that's reasonable. There are trials ongoing looking at that question. So hopefully we'll we'll get data in that space. I think it's also important to recognize some of the toxicities that we see in early stage, in advanced stage disease, with, essentially immunotherapy being able to cause an itis in any organ in the body. The endocrinopathies, thyroid abnormalities, diabetes, adrenal insufficiency are generally irreversible. Some of these rare toxicities can be fatal. Fortunately, they're rare. But most of these can be managed with immunosuppressive therapies and reversed. Some patients, depending on the severity, can be challenged or not re-challenged. But I think it's the one take-home message I just want to make for immune-related adverse events is that these toxicities can occur even after patients have moved on to other therapies. And it's always important to think about your patients, anybody who's been exposed to immunotherapy, be it in the early stage setting, the metastatic setting, you always want to think about immune-related toxicities in that space. And, these can present months to years after exposure, even after they've moved on to another therapy. So I'd like to shift gears and just talk a little bit about antibody drug conjugates. Now, I think this is the next wave of therapies that are showing so much promise. We've already got a handful approved and many others coming down the pipeline. We have, obviously trastuzumab deruxtecan, which is approved for HER2-positive disease, as well as HER2-low disease. Sacituzumab govitecan, which targets TROP2, is approved in both advanced triple-negative breast cancer as well as hormone receptor-positive disease, and then a number of novel antibody drug conjugates that are in development. Datopotamab deruxtecan, which is another ADC targeting TROP2, showing a lot of promise in early phase trials. Randomized phase 3 trials are ongoing, and we'll, I think, hear some data at an upcoming meeting for hormone receptor-positive advanced stage disease. The triple-negative trials are ongoing. And then patritumab deruxtecan, which is a HER3-targeted ADC. So really exciting data. And I think what's allowed us to take ADCs to the next level here are that many of the ADCs that we have in development now have these potent bystander effects. So even if there's heterogeneity within that tumor microenvironment, we can see really robust activity with tumors. So the ASCENT trial led to the approval, the full approval. There was already an accelerated approval, but full approval of sacituzumab for second line and beyond triple-negative breast cancer. It was shown to be better than therapy of physician's choice, a significant improvement in PFS and OS. And so I would suspect by now, Bill, you and Yuan have had the ability to use this in your practices, probably in triple-negative disease as well as in hormone receptor-positive disease. Any thoughts you want to share about your patients and how they're doing with sacituzumab?
Yeah, so I think, I share the enthusiasm that you expressed about the antibody drug conjugates as a class. And, sacituzumab govitecan has been used now for a while. And I think it is a good drug. It's shown activity. The side effect profile, sometimes you have to pay attention to some of the GI symptoms. But I think if you make patients aware, and in some cases you have to, in a sense, prophylax for some of those things, patients do okay. So I use it very commonly. I think it's even moving up a little bit in some cases, particularly in select patients where they are not PD-L1 positive. We have used it earlier, but I think the drug is good.
Yuan, do you start out lower? Are there patients where you maybe adjust your starting dose or preventatively, prophylactically give growth factor? Any challenges in your practice?
Yes, so I think I'm getting more comfortable using this agent, and usually do not dose adjust unless patient had been heavily pretreated, have a lower counts to start with, and I'm paying a lot of attention to use growth factor more proactively rather than waiting. GI toxicity appears to be manageable, and I think the introduction of the trastuzumab deruxtecan in the space now bringing a lot of interesting discussion in the clinic. Often, which agents to go first. I'm sure you all have their answer, and I still try to stick with sacituzumab govitecan first because of some benefits.
Oh, yeah. No, I think that's great. And, again, I think we're using it more and more now that it's approved for hormone receptor positive disease as well. And so that's a great segue into talking about trastuzumab deruxtecan, Yuan. I think, as we all know, HER2 low disease, we now have an approval for TDXD for these patients. About 2/3 of hormone receptor positive patients have HER2 low disease, and about 1/3 of patients with triple negative breast cancer, or I should say hormone receptor positive, or I'm sorry, hormone receptor negative HER2 low disease. About 1/3 of these patients are eligible for this therapy. And I think the question does come up, how to sequence, right? We've got great data with trastuzumab deruxtecan from the Destiny Breast 04 trial. It was predominantly a trial that was done in hormone receptor positive disease, but 10% of the patients did have hormone receptor negative HER2 low disease. And we saw similar improvements in PFS and OS, just really remarkable findings here for patients with the triple negative breast cancer cohort here, those 10% of patients. So it does come up a lot of times. How should we sequence? What should we do? Bill, do you start with sacituzumab first, or do you start with trastuzumab deruxtecan first? Or
Yeah, I do. I don't disbelieve this data. I just think obviously we have more data with SASI than we do with trastuzumab deruxtecan. And, I think probably most of us would, or at least we'll see what you guys think, if they receive sacituzumab, I wouldn't exclude giving them TDXD next, trastuzumab deruxtecan. So that gets to that issue of the sequencing of antibody drug conjugates. We don't have a lot of data yet, but since the target is different, I wouldn't hesitate. And the payload's different, so I wouldn't hesitate to use these two drugs in sequence.
Yeah, no, but you raise a good point. Neither one of these trials included patients who'd been treated with the other. So it certainly is a issue which comes up, and definitely something we need to think about. And there are trials being planned, randomized trials, to look at sequencing these agents in both hormone receptor positive as well as hormone receptor negative disease. So
but
I think
on that point, sorry to interrupt, but on that point, are you guys starting with sacituzumab?
Yeah, I do generally start with sacituzumab for the same reasons you and Yuan said. The data from Ascent is just so much more robust. It was a 530 patient randomized phase 3 trial as opposed to an exploratory analysis. Yeah. And so I do have a tendency to start with sacituzumab, and then, we'll absolutely go to TDXD for those 1/3 of patients who are eligible thereafter. So I'm just going to quickly go through. I want to leave enough time for our third podcast here, but quickly just go through some data for some of the antibody drug conjugates in development. Datopotamab deruxtecan is another antibody drug conjugate which targets TROP2, just like sacituzumab govitecan. And again, in a phase 1/2 study, efficacy, which is pretty comparable to what we saw with sacituzumab in a heavily pretreated triple negative breast cancer population, response rate of about 35%. And, what was interesting in this trial was that there were 10 patients who'd previously had sacituzumab govitecan and had progressed and went on to get datopotamab deruxtecan. So antibody drug conjugates targeting the same antigen, but with a different toxic payload, although the toxic payload, they're both topoisomerase 1 inhibitors. There was some efficacy seen by even sequencing these agents. So I think it's really exciting to think about how we might be able to use these agents in sequence. Obviously, datopotamab is still in clinical trials. It's not commercially available. It's going to be some time before we have this agent. But again, very exciting to think about, although will be a lot of work for us to figure out how best to sequence these agents moving forward. And also, there were a handful of patients who'd had prior trastuzumab deruxtecan, just a handful of patients, but again, some disease regressions seen even after exposure to a drug with the exact same toxic payload, but targeting a different antigen. So I think very exciting to think about the future here. There are obviously trials that are ongoing looking at these agents earlier. So we've talked about how, these are approved in the second line and beyond setting. The Begonia trial was a small phase 1/2 trial looking at combining immunotherapy with some of these ADCs, specifically TDXD and datopotamab deruxtecan in patients with previously untreated metastatic triple negative breast cancer. And we can't really draw any conclusions about the efficacy of the combination and if there's synergy, but there appears to be safety and tolerability here. So there are randomized phase 3 trials ongoing looking at immunotherapy plus antibody drug conjugates, both for PD-L1 positive triple negative breast cancer as well as PD-L1 negative breast cancer. And all of these agents are being moved up into the frontline setting and even the adjuvant and neoadjuvant setting. So it's going to be really exciting to think about where these drugs are going to play out. I don't know, Yuan or Bill, if you wanted to add anything. This is just a very high level summary of what we've talked about and how we think about sequencing these agents. And if there's anything that you want to comment on, but, I think for the PD-L1 positives, we really reach to chemoimmunotherapy first, given the survival advantage for mutation carriers, PARP inhibitors very early on. And then we've got a handful of antibody drug conjugates, which are available, and then others that are in development that look pretty exciting.
Yeah, I don't have anything to add.
Yeah, nothing to add. Maybe just another box clinical trials, but we're talking about standard of care.
Yeah. No, absolutely. We always like to think about trials, but not everyone has access and not all patients wish to participate, but it's certainly something I agree with you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.